All right, guys, welcome back. So, okay, where are we? Let me see. So here is this. So we already go through all this. The blood transport. How does blood transport O2 and CO2? The next thing is how do we breathe? So breathe involve several voluntary muscle. So those are skeletal muscle involving your diaphragm, involving your intercostal muscle. So you breathe in, breathe out, breathe in, breathe out. You all know you breathe, right? Now you breathe in, breathe out, breathe in, breathe out. Let's try that. If you breathe through a tube, right here, a tube, and then connect that tube to a machine, we can detect breathe in, breathe out, breathe in, breathe out. And so here is that what you see. You have breathe in, breathe out. Here is lung volume. When you breathe in, expand. When you breathe out, shrinking, right? Become smaller, expand, recoil, right? Expand, recoil. You only make effort during the resting breath. During the normal breathing, you only make effort for exhalation. Breathe out is just recoil. Just lung ribs get recoil back. So you pull it, relax, pull it, relax, pull it, relax. So that's this. Breathe in, breathe out, breathe in. So you can breathe in more. So your lung expand more. You can breathe out more. So your lung can decrease more. Lung volume can decrease more. So that's that. So you have that huge range. We usually don't use those huge range. We only use these volume. So for these huge reserved volume, we have the inhalation reserve volume, we have the exhalation reserve volume. But we usually only do this. This is like wave, like ocean. Coming, go, coming, go. So we call it a tidal wave. No, tidal volume. Yeah. So that's that. All right. So this is what we call a spirometry. This is a very low cost. You basically don't cost anything when you breathe through the tube. And but it can detect two major lung disease, two major type of lung disease. Yeah, so we will see why do we need to learn this and how is that important. So let's take a closer look to this spirometry. This spirometry measure your ventilation. You can do your ventilation. If you don't, then machine can do ventilation for you. But machine control is not good, because these involve a lot of, this is not, on off. It has a smooth transition. That's the beauty of our body. We have smooth transition, but machine will, it's like, it's, yeah, so it's not that good. Yeah, so here, the way when you breathe, you need to know this terminology. Basically, I will present. I just let you know, be clear that I will label it. I already did, and then I will erase this label and then ask you why is it. Here are 1, 2, 3, 4. 1, 2, 3, 4. Maybe only 4. Lucky you. All right, 4. So what do we have here? The most important one is the tidal volume. Yeah, tidal volume. So this is normal breathing. The amount so the lung volume. And then we also have the reserve, inspiratory reserve, and expiratory reserve. And so you have more room. We have some area in the lung that we can never use. So you exhale, but you can exhale to a level that you cannot squeeze them to the end, right? So this is called residual volume. Yeah, and the total is total lung capacity. So that's all. And we will do this one in the lab, so you will know that, okay, how to see this in the machine. Just some, that's a picture, and here is just text. Basically, that's the same thing. Tidal volume, vital capacity is right here. Oh, vital capacity is the volume, vital, right? So that's for your breathing. So this is it include the IRV, inspiratory reserve volume, TV, tidal volume, and the ERV, expiratory reserve volume. So that's tidal, vital capacity. Inspiratory and expiratory residual volume. So that's the thing we all talked about. One thing we have not talked about is this one, minute ventilation. Minute ventilation is very much like heart rate. So you have how many beats per minute, like cardiac output. Heart rate is how many beats per minute. Here is how many breathing per minute. It's usually about 12, 10 to 12. How many beats per minute? And then you times the amount of each contraction, stroke volume. So you got the cardiac output. CO equal stroke volume, SV times heart rate. So that's cardiac output. Breathing, the same thing. You have how many beats, how many breathing per minute? 12. And then each time, how many volume you breathe in and out in that cycle? That's tidal volume. So you have the tidal volume times respiratory rate. You have minute ventilation. So you need to know that. So basically that's minute ventilation equal tidal volume times the respiratory rate. Yeah. So that's it. Another thing we can also use, we can also measure from this spirometry is this. Later we'll talk about that. Yeah, is this one. It's called forced vital capacity and forced expiratory balance. Before we use this one, we talk about the disease. Yeah, so I want to give you the context. Let me get some water. The context. Why do we need to use those? So have this device is good, and able to measure this different thing is good. But how do we bring this to the real world that we have so many disease, so many sickness with patients? We need to take care of them. How do we use that device or that method to help them? So I want to bring you to the context that the lung disease is one of the leading cause of death. It's in America. It's also even more prevalent around the world. Let me show you here. So this is the data from CDC. Does it show you here? Yeah. Center of Disease Control, something like that. CDC, yeah, disease control. So this American data in 2000, man, I didn't, oh, here, 2020. So it's 4 years ago. We might have a new one. So you can see that, all right, so that is COVID time. So we have a lot of COVID death, but you can see that leading cause of America, heart disease is a number one. Yep. So we learned about cardiovascular system. The very next thing when we start to learn about the organ system. Cancer is the leading one. No, this we don't really have good progress. To be honest, the death is still pretty good, pretty bad actually, pretty bad. That we can extend the survival time, but we cannot increase the survival rate. So basically that we can only let the patient die later, but not clear of tumor. Basically, it's a lot of tumor we cannot, but we do have some good, like outcome from some type of tumor. Accident, yeah, stroke. This is another cardiovascular, cerebrovascular cardiovascular disease. Here, COPD, chronic obstructive lung disease, low respiratory disease. So chronic low respiratory, so it includes several things. Yeah, so that's that. This is respiratory disease. This is leading cause. Why is it? A lot of this is due to the smoking. Here in America, we we have the battle against tobacco for so long, right? We have no idea in the beginning, and people smoke, and that caused a lot of lung disease, even lung cancer, and other cancer too, other disease. It caused because that toxin can go to blood, cause vessel injury. It will also cause different organ injury. So that's not good. All right, now we know we kind of battle against the tobacco, but now the new thing is e-cigarette. Uh, I can, all of you has that experience that you may be, depend on that e-cigarette right now. I know I totally feel sympathy. I know that smoking is not good, but nicotine is very addictive. Yeah, so once you get on, it's difficult to get off. I know people can get off. It's not impossible, but you just need to uh, get some support. Nobody can fight this by themselves. You need to get some support. You need to get some facility to provide you maybe a patch, nicotine patch. It will provide you some nicotine. With that, you still have nicotine, but you get rid of those behavior, because a lot of the smoking is addiction is not purely chemical, it's neuron. So it's the brain, is the nerve. And when we have the habit of conducting smoking like behavior, when we are stressed, when we are tired, that neuron feedback will attach to you. But with the nicotine patch, you help yourself to not repeating those action again. So you don't really do that action, and by doing so, you cut some of this connection, and you would have some nicotine, but you don't have that action, and gradually you will find some joy to help you to release dopamine, help you to have the joy again, or have the joy, right? Or focus of your life on some other thing. Then you don't depend on that nicotine patch. So you can gradually clear from it. There are many good examples that people quit smoking. Yeah. And so it's not impossible. And yeah. So that's why we have a lot of lung disease. Yeah. So the thing is that the lung disease has two types. Here, we have the restrictive lung disease and obstructive lung disease. The major one is the obstructive. I have to say that, for example, the common one is called COPD. Let me write it here. I think we probably will talk about this one in the lab. Let's see here. I think people know this term, right? It's not LAPD, right? It's not. It's chronic obstructive pulmonary disease. So that's the COPD. Yeah. Right. So that's that. So it's an obstructive lung disease. It's one type of obstructive. So this is quite common. And another one is called restrictive. Yeah. So there are two types. Now, what's the difference in the airway? So let me show you here. Let me show you airway again. So here is the respiratory tracts. So all these tracts can have a disease. All right. these tracts can have disease. It could be the nasal, pharynx. If there's disease here, we call it upper respiratory. So this is not that fatal because it doesn't really get into it. This part is easier to treat because this is accessible. But what will get worse is that when you reach to the lower respiratory tracts, trachea, bronchial, and the lung, it will become difficult to treat. So this is called lower respiratory disease. All these areas, there are two types of the injury. One is that these airway get blocked. If this airway get blocked, air cannot come in. So you have the hypoxia, low oxygen supply to your body. What can be that? So it can be inflammation. If there's any inflammation, how can we have the inflammation? Well, if people are smoking, then the mucus accumulate in here, so air cannot easily go through. Some people has the asthma that allergic to the air allergen. It will cause vessel constriction, bronchial constriction right here, bronchial constriction, and the air cannot easily go through. With that, we call it obstructive lung disease. So if the airway is blocked, it's obstructive lung disease. Another type of disease is that once this local tissue is injured, when it's injured, it's just very much like injury in your tissue. You will form scar, right? You have this scar to take the place where you lose the cells, because you need to maintain the integrity. You need to connect every tissue all together, so you form scars. These scars can be is another way to think about it is fibrous. So this fibrous material will present in your injured location or lesion, right? So you will form a scar right here. When you have these fibrous try to hold everything together, they are trying to keep everything after the injury, trying to hold everything together. What can be that? Inflammation, COVID, for example, you trigger a lot of inflammation. They try to kill the virus. Also, the smoking can also cause that. And so you have a lot of fibers. With that fibers, they hold everything together. Even though they save the organ, but they compromise the function of the organ. Now the lung used to be able to expand, shrink. With that fibers on it, they cannot expand. So we call it restrictive lung disease. If it's not the airway, if the lung cannot expand, we call it hard. Basically, it's hardened, right? We call it restrictive lung disease. So that's these two types of disease. Let's go back here. Obstructive lung disease is the airway. Restrictive lung disease is that lung cannot expand. All right, so that's that. We have these two types of disease. I think I have some example. Obstructive lung disease is carried by airway obstruction, all right? And it can cause by such as narrowing of the bronchial or bronchioles, a larger one or smaller one. And it can be caused by the smooth muscle constriction or mucosa or accumulation. So, and it's either chronic obstructive pulmonary disease, asthma. Those will cause obstructive lung disease. Restrictive is that the alveoli become fibrous and the lung cannot expand. So it can be caused by pulmonary fibrosis or pneumonia. So this is the infection in the alveoli, and we can also probably add COVID here. COVID can also, if we take the X-ray, you can see the lung is becoming very white. Is those fibrosis or accumulation of fluid? Yeah. So that's that. So that's these two. Now, how do we use spirometry to measure, to analyze, or to determine what type of the lung disease the patient have? How to? So the way to do it is to perform, in addition to use the spirometry to get these breathing, we can ask the patient to hold on to this one. And what do we do is that, okay, hold on to it. And we ask the person to expand the lung as much as possible. So we basically will make the lung volume to increase to its maximum total lung capacity, reach the maximum. And then what we ask is that breathe out as fast as possible. Very quick breathe out. So with that, what we got is something like this. Let me show you here. Something like this. So here is the time, and this is the lung volume, say lung volume or liter. What we got is something like this, but very quickly it plateau out. So something like that, plateau out, and we get something like this. With this, we get two numbers. One is that this one is second, 1 second. This is 2 seconds. This is 3 seconds. Right? So we have second, breathe out. Long liter, the air get breathed out. Air get breathed out from the beginning down. So we can get to number one is that in that second, in that first second right here, we can get this number, this liter. We can hold on, right? We can measure how much air to go out, how much air to go out in that second. In that second, we call it forced expiratory volume, right? One. Maybe something put one here. FEV1, forced expiratory or forced exhalation volume. That the amount you breathe out within a second. Like that. Breathe out. Yeah. And that will give you the airway. If the airway is narrowing, if the patient has the airway narrowing, let's use another color. This is the patient, the red one. We will get something like this because airway is blocked. You just don't breathe out, right? So it increases very slow. So your FEV1 right here will be much lower. So that's that. So that's one measure. Another measure is the total lung capacity. Say your lung, right? You spend that much, and you breathe out totally. So here is that when you reach it right here, here, the plateau right here. This amount, when you reach the plateau, that basically is how much you carry in your lung, right? So that's the vital capacity in a way. But here we call it forced vital capacity. That is the same thing as vital capacity, FVC, forced vital capacity. This one look at the amount of the volume that your lung can hold. If your lung has restricted, you cannot expand, the forced vital capacity will be lower. So that's these two volume. So let's go back to the close. Let's go back to this slide here. So that's the same thing here. You breathe out, you have the FEV1. This is the FVC right here. So this time, this volume here is the FVC, here is the FEV1. So that's a two volume we can also measure. And yeah, we can also measure from the spirometry. These two has clinical relevance. FVC indicate, low FVC indicate restrictive pulmonary disease. Low FEV1 indicate obstructive pulmonary disease. So that's that. All right, that's gonna be the quiz question. Okay, which one provide you a diagnostic measurement of to distinguish whether the patient has obstructive lung disease or restrictive lung disease. I think that's that. All right. So let me close this one. Do we have more? Yes, we have final one. So this is the last thing that we are going to talk about. This is related to, let me show you here. So this is going to everything connect together. Let me stop sharing. Let me share this one. Remember that in the very first lab, we talk about the homeostasis right here. So here is the homeostasis. We talk about different homeostasis, but the one that associate or related to the breathing is this one. Increase in plasma CO2. We want to maintain the CO2 level to be low. We want to maintain good O2 level to be high. And so we need to control our breathing by achieving that. And so here we have the stimulus, sensor, integrated effector. Yeah. So this is the one that we are going to talk about here. That is, let me stop sharing and go back to here. Share screen. So breathing, we don't try to control we don't try to maintain the same breathing pattern over and over again. That's not the purpose. Our purpose is to use breathing to control pH level because that is critical. Our body need to have a stable pH level. So right here, our body need to have a stable pH level. So in our body, we need to maintain the low pH level. And so we have the chemoreceptor to sense it. So in order to maintain that homeostasis right here, homeostasis, we need to have the sensor. Those sensors are different kind of the nerve ending. They will sense, in this case, they were chemoreceptor. They are located in the blood vessel. They will sense low pH, indicate high CO2, or they can also sense low O2. They are different kind of sensors sensing different things. Then they gather this information to the integrator. As I mentioned earlier, we have two centers for the breathing. One is the pons or pontine. The other one is the medulla. And so those two will get integrated. Basically, these two, one is to control the frequency of the breathing, and the other one is to control with that frequency, how strong you have with that breathing. And then these one will get those information, and in order to maintain the homeostatic level of pH, CO2, and O2, we need to have an effector. The effector will be the breathing muscle. So if the CO2 level is high, if the pH level is low, if the O2 level is low, then we will force that muscle to breathe much faster. And as a result, we can reduce the CO2, reduce the acidic, and also supply the body with enough O2. That's why when you run, your breathing gets faster. Why? It's because that when you exercise, you use a lot of O2, CO2, you use a lot of O2, you produce a lot of CO2, and that will get detected by the blood vessel. Tell your brain, then you start to breathe faster. So that's that. All right. So that's everything in the respiratory system. And let me know if you have any questions. And I will see you next time.